Thank you so much for joining us for this edition of SBB University, where we are going to cover your health from your head to your toes. I am delighted today to bring on 5 of my partners with Seniors Blue Book. We're going to start with Miss Natalie over with Lee Health. How are you this morning, Natalie?
I'm doing great. Thank you, Amanda. Thank you for having me.
Absolutely. So tell us a little bit about yourself and how you got started with Lee Health and what your specialty is.
I'm a physical therapist and have been for almost 28 years. I've been with Lee Health since 2001, so I'll be celebrating a proud 20 years this year. I have decided to specialize in what's called vestibular rehabilitation, and so that involves a special type of therapy to help people who have complaints of dizziness, vertigo, and that includes balance problems, and we work on fall prevention as well.
Fantastic. Thank you so much, Natalie. All right. Over joining us from Park Royal, we have Miss Amber. How are you this morning?
I'm doing really well. Thank you.
Tell us a little bit about yourself, how you got started with Park Royal, and a little of your specialty.
Yeah, so I am actually the Chief Operating Officer for Park Royal Hospital. Been in this role for about 9 months now. Before that, I did a little bit of intake, risk management. I've worked in utilization review. I've worked in behavioral health for over 7 years now.
Fantastic. Thank you so much. All right. Dr. Kai Lewis is joining us from Quigley Eye. How are you this morning?
Hey, good morning.
Good morning. Tell us a little bit about yourself, how you got started, and what your specialty is.
Well, I'm a ophthalmologist, a cornea specialist, so I do cataract surgery as well as corneal transplants, as well as some refractive LASIK and surgery as well. I've been with Quigley Eye Specialist for about 4.5 years. Prior to that, I worked in Stockholm, Sweden. I worked as a cornea specialist. I taught residents for about 4 years there. So I've kind of been around and glad to be here with you guys and share some of the stuff I have to offer.
Yeah, and interesting. You said you do cover all the way from Charlotte County down into Naples, right?
Correct. Yeah.
Awesome. All right, Dr. Ebert, how are you this morning?
Hi, I'm good. Good. Yeah, I've been a chiropractor for over 35 years here. Originally in Naples, and I relocated my office up in the Bonita Estero off of Coconut. So, you know, I work with a lot of golfers and very active patients. And I do have a certification in sports injuries. So, you know, I enjoy what I do, and I'm still having a good time getting through this year. And but it's worked out pretty well. So.
Perfect. Thank you so much. And last but certainly not least, we have Dr. Ann Rasmussen joining us from Doctors Hearing. How are you?
I'm doing great. How are you today?
Very well, thank you. Tell us a little bit about yourself, how you got started, and what your specialty is.
So my name is Dr. Ann Rasmussen. I am a doctor of audiology. So this means I specialize in hearing loss, tinnitus, imbalance disorders related to the ears. Let's see, I started going to school. Oh gosh, long time. So I started actually, let me back up a little bit here. I started working with ears at the young age of 19 years old. So I've been working with ears for 22 years. Don't do the math, okay? But I opened about 10 years ago the only fully mobile audiology service here in Southwest Florida. And then we just exploded. We also have 3 offices, 2 in Naples, 1 in Fort Myers. And it's good to see some familiar faces. I see plenty of people here who I've worked with in the past.
Fantastic. Well, thank you so much for joining us today. I know you have a personal story that accompanies your passion for what you do. Do you want to just briefly touch on that?
Sure. Yeah, I tell everyone I get to do what I love every single day. So when I was 16 years old, my much younger sister was born with profound hearing loss. So that's why at 19, and I was in college, and I decided, you know, I'm going to help people with hearing loss. Luckily, I just happened to have a knack for it. And so I went on to earn my doctorate in audiology. I wanted to know everything there is to know about hearing loss and how to help people with hearing loss. 12 years ago, my daughter was born with hearing loss. So hearing loss runs in my family. Luckily, mom is in the right field.
Yeah.
And so, I make sure that every single patient is treated like family. And I like my family. Okay. So I get to do what I love every day.
That's perfect. Thank you so much, Dr. Ann. All right, Natalie, you cover the field of physical therapy and balance. So I want you to talk to me about how you promote optimal health and prevent injury.
Well, to me, the key is education. And I've been fortunate with Lee Health to get into a program coordinator role. So I don't see patients on a regular basis anymore. In fact, I teach our therapists within the hospital, within the outpatient clinics, all throughout the continuum of care about balance and vestibular rehabilitation. And I put together a lecture series. So I'd love to have any of you be part of our lecture series in the future if you're interested. Also, I run some balance screening events, and I participate in these activities. So to me, the basis is all about education, and that's what you're helping to provide.
Perfect. Yes. And with your expertise really being in balance, what are some simple things that you can do to prevent injury?
Well, the first thing we have to do is to prevent the fall, right? And as we get older, although it's normal to see some changes in balance, it's not normal to fall. And unfortunately, a lot of people think, well, I'm just getting older, so it's normal to be dizzy all the time. It's normal to fall, and it's not. The idea is to pick up on the precursor signs. So when there's subtle changes in balance, that's when we need to get checked. Just like we get the eyes checked, Dr. Kai Lewis would say you have to have that done every year. The hearing is also checked. Well, here I am with balance. I wonder why we don't do a balance check every year. So maybe this group can push a little bit, and we can have that for our community elders. I think that would be a very wise thing. So it's all about prevention, maintaining good balance, and staying active. If there are problems that develop, then a person should ask to be evaluated by a balance specialist.
Yeah, that's perfect. Now we're going to jump over to Dr. Ann to talk to us about a couple of things. So what's the difference between an audiologist and a hearing aid specialist? Because I know you've got a great explanation that you want to share with us.
Sure.
Today.
Okay. So a hearing aid specialist is someone who has a certification. Usually takes about 6 months to earn the certification, and they work with hearing aids only. So a doctor of audiology goes to school for 10 years. What do we do for 10 years? Well, we learn a lot. So hearing aids is included, but we also learn about the etiology of hearing loss, tinnitus, so better known as ringing in the ears, also balance disorders related to the ears. So it's good to see you again, Natalie.
Thank you, Dr. Ann.
I also strongly believe in continuing screening and education. I believe that the community really has a lack of knowledge about imbalance related to the ears and falls. And like Natalie, it's my job to keep patients out of the hospitals. I want to see them nice and healthy. So I'm happy to help promote that.
Absolutely. And there's such an interesting lecture that you've given on the connection between untreated hearing loss and balance issues, as well as your memory. So talk to me a little bit about that, because, our broad spectrum of your health from your head to your toes, people don't realize that your ears are so important.
Our ears are connected to our balance system, but also cognition. So when I perform basic evaluation and also annual evaluations, what I check for is I start with, the ear canals, just checking for something as simple as earwax. Because believe it or not, if we have too much earwax and that presses upon the eardrum, then presses upon the inner ear, that can cause imbalance and falls. So we check the middle ear, the mechanical components of the ear, eardrum, bones, muscles, eustachian tubes, to see if this causes hearing loss, imbalance. The inner ear as well, if we have any nerve damage within the inner ear, then this nerve damage causes a lack of sensation, a lack of stimulation to the brain. Okay. And so if we have a lack of stimulation to the brain, guess what happens? Our brains get a little lazy. So just like any muscle, we have to use it or lose it. Exactly. And so when we start to look at hearing loss, I feel like hearing loss is a general term, but really what we're looking at is nerve damage within the inner ear and lack of stimulation to the brain. And when we have lack of stimulation to the brain, there is decades of research. The most, I guess, well-known research is by Dr. Lin. He's a neurotologist out of Johns Hopkins University. And what this research shows is that when patients cannot hear, they have a lack of stimulation to their brain, which can can contribute to memory loss, Alzheimer's, dementia, basically cognition issues, up to 300% more rapidly when the hearing loss is untreated.
Yeah, that's pretty significant data, for sure. So definitely get your ears checked. I think it's really important, no matter the age. I think we've talked about this even for myself.
Oh, absolutely.
You need a baseline hearing test so you can track your progress.
Absolutely. So my daughter was fit with hearing aids at 3 years old. Half of the patients who we fit with hearing aids are now under the age of 55, under. And I've had patients come in and tell me that wearing hearing aids has taken a few strokes off their golf game. I don't know if that's true or not, but sure, I'll run.
That is a perfect segue into Dr. Ebert. Because I think you probably see more golfers than anything else, golfers and tennis players, right, Dr. Ebert?
Yeah. Yes.
So what type of conditions would you say chiropractic doctors see most often?
Well, I think it's usually neck pain and low back pain. That's usually who's coming in, but we can adjust shoulders, elbows, knees. So we also work on people's extremities. But I would say the majority is neck pain. Sometimes the radicular pain down into their arms, sciatica, stenosis causing the leg pain. Certain things you just can't, you're just patching up and you're working with the patient. But that's probably, I had a patient yesterday, never thought that we could help with headaches. And I said, that is one area that I really feel confident that I can help a patient with, especially with upper cervical area, migraines and regular headaches. And they're usually in there for neck pain. And then, if I ask, it's like, oh, well, that's just normal for me. I get 3 headaches a week. And it's like, no, that's not normal. So that's an area that I think we're underserved. People just don't realize that we can help in that area. But yeah, really those types of young or old, kids fall and sports and all the different activities that we do. And just talking about with falls, some of my patients, I'm like, this isn't just about your back pain. If you're in a lot of pain, you're susceptible to actually trip, fall, they're inflexible. And, so once we get rid of their pain as much as we can, then it's really trying to work on a good stretching routine for them so that, especially my older patients, that they can keep that flexibility.
Yeah, for sure. And I know you're an advocate of that holistic approach where you're looking at everything, including nutrition. That's one of your hidden passions, right?
Yeah. I just, it's hard to change people's lifestyles, even for us, with our own activities. But, just trying to point out as much as I can of maybe not trying to revamp everything, but just, hey, you could do this. And sometimes just that one or two things can really make a pretty big change in their lifestyle. So, trying to hit some of the big areas that will give them the biggest bang for the buck, I guess you'd say.
Yeah. Now, some folks are scared of getting their neck cracked or their back. It can be a little intimidating. What would you say to a patient that may be a little nervous about that?
Well, I had a patient yesterday who had never seen a chiropractor. And she goes, oh, I'm kind of scared. And when I said, well, what are you scared of? She goes, I don't know. She goes, I'm just scared. Some people just don't like the idea of a popping or a cracking noise. But that audible noise is really just mobility. You get it even when you just do it on your own. So I try to educate that it's really not, it's like your knuckles. It's not that something went in or out. It was just motion, and it's a gaseous exchange in the vacuum of the joint. But when people say they're concerned or they've heard this or heard that, I always tell them we have the lowest malpractice out of all the physicians. I go, it's really hard for us to hurt a person. And it really is. And when it comes to the neck, this isn't 007 adjustments, So usually it's a man or, I go, I'm not, we're going to go nice and easy. And there are other techniques that you can use. If I get someone who they'll just say, that just freaks me out, or hear a popping, even if they hadn't really ever been adjusted before, we have instrument that we can use that actually you don't have to do the popping noise to get motion. So there's other ways of adjusting, and mobilization, and physical therapists do a lot of mobilization where chiropractors actually put a thrust, and that's kind of the area that we're really good at. So,
Awesome.
So not be scared of us. It's very, and usually just educating to them. And, I'm kind of like, well, there's people coming in and out of the office and everybody's okay. I've been
Still walking out.
Yeah. So nothing to be, I think it's just so many patients have not been exposed to chiropractic, where now our education is certainly, it's an 8-year program, and 4 years undergrad and 4 years chiropractic. So the education has really improved also.
So you're up there with Dr. Ann. All right, Dr. Welcome. How are you?
Fine, thank you.
Good. Now, I am famous for butchering last names, and I know I'm going to be famous for butchering this question. What is keratoconosis? Did I say that almost right?
Well, keratoconus, but you're close, yeah.
Talk to me about that.
Well, I'll talk to you about that in conjunction with several other things, because I think it's important for the patient population we're seeing. So keratoconus is in the front of the eye, which is the cornea. That's basically the clear glass window in the front of the eye. Some people have issues with it. Some folks, though, that clear glass window is weaker than others. Mm-hmm. And so as a result, the shape changes. And so I usually give this analogy, like the cornea is basically interlocked, and with keratoconus, that structure is weakening to the point where it starts to slip. And as a result, it pushes forward or changes shape. And that can really change the vision. So someone can have a lot of what we call astigmatism, a lot of nearsightedness, and that can change over time. That can happen more in the younger folks, but it can also happen in people plus 50. It's called a different term, but it can happen as well. Now, because I'm a cornea specialist, I see that, and in combination, so our population, which is 50 plus 60, there are other things that are happening as well, not just cataract, because that's all we hear about. Oh, someone has cataract, let's take care of it. But what I do is I look at not just the cataract, but I look how the cornea is affecting the vision, and what do I need to do to address the cornea as well as the cataract. And so mainly I see people with shape issues, like old keratoconus that's sort of worn out, but still has caused significant change in the vision. I see people with another condition, which is called map dot dystrophy. And the reason this is important is because on the surface of the eye, there's cells, there's multiple layers of cells. And the most anterior cells, the cells right on the surface, sometimes in folks with this condition, the surface sort of moves on top of each other. So the eye basically looks like a map on the surface of the eye. And as you can imagine, someone comes in and say, man, I think my cataract's getting worse. I can't see as well anymore. And someone does their cataract surgery and they're still not seeing well enough. So I look at all these things. So I've been in situations where someone comes in for cataract evaluation, but we take care of the surface of the cornea, and then they can sort of put off the cataract for quite a while after that. So those are the things I look at. So I look at all the aspects of the cornea: keratoconus, shape issue, map dot, which is a surface issue, and then finally the back of the cornea, called endothelial Fuchs dystrophy, where the cornea swells and you can have issues with the vision. So all those things I look at and try to address, not just the cataract in folks.
Yeah, and that is
So,
that's a big topic. That's what you hear about, especially here in Southwest Florida.
Exactly.
Now, is there anything you can do to prevent it?
Well, unfortunately, so keratoconus, we don't know much about. It's a multifactorial thing. So what we do know is folks have allergies, and sometimes they're rubbing the eye. So we've sort of seen this consistency where the more you rub your eye, you have keratoconus. And so, but we just don't know exactly. So you have a genetic predisposition. Now, the thing is with keratoconus, it worsens when you're younger, but at some point it stabilizes. And usually it's around 40, 50, it stabilizes. But if your vision is already pretty bad, then you have to address that in some way. So all these conditions are genetic. So eventually they do become a problem. So we can, so with keratoconus, there's a way to fix or at least stop the progression. We catch it early enough. We treat the surface. That would be one way to do that. And with Fuchs dystrophy, we give drops to see if that can help with the swelling. And then also, if the cornea really does not do well, then I do these partial, where I remove just the cells that don't work. And it's a corneal transplant, but I don't remove the entire cornea. I just take the cells that don't work and replace it with another layer. So those are the things I do for those particular patients.
That sounds intense.
Maybe.
Technology really has come a long way. Oh,
definitely has. From 10 years ago to now, I do things. None of this I learned during my training. So all these were sort of newer innovations that came out since I've finished training.
Very cool. Well, thank you so much. All right, Miss Amber, we're going to talk about mental health now. This is a big subject in 2021 for sure. Now, what are you seeing in your profession around the ages presenting with mental health distress right now?
Yeah, so COVID certainly made a lasting impact on everyone, which has only intensified the number of patients that we see, both inpatient and outpatient. So we don't serve the adolescent population. What we serve here at our facilities, 18 up to the older adult. We do have a heavy geriatric population here in Southwest Florida, and our unit stays pretty full there. But what I can say about the patients that come to us, they come from all walks of life, various levels of distress. So they may be in an acute crisis, they may not be in an acute crisis. Some of the more minor cases that our admissions department's going to triage is going to be someone that is not in an acute crisis where they're wanting maybe medication stabilization. They actually may have had surgery or gone to a chiropractor for chronic pain, and they're battling this depression because it's affecting their ability to function in life. So they're looking for some therapy to process those stressors, and they would do that with medication stabilization and therapy in an outpatient setting. Then there's those who are in an acute crisis where they need a 24-hour nursing locked facility inpatient with us. They're probably They may have attempted to take their own life. They may be threatening to take their own life. They may be so acutely psychotic, chronically institutionalized, non-compliant with medication. It may be a geriatric patient who has Alzheimer's or dementia, and COVID really hit that community hard this year by isolating them from, loved ones, and then all of the effects that had in the nursing homes and the ALFs and SNFs. So, like I said, across the board, we've definitely seen an increase in all areas of mental illness and substance use as well.
Yeah, you actually are hitting the nail on the head for your next question. Much like mental health has a big light shined on it through COVID, so does addiction. This crisis has caused people to turn to drugs and alcohol. What would you say the link is between mental illness and addiction?
So what we see, often mental illness and addiction coexist. So what that means is our patients more times than not are coming to us and being treated for dual diagnosis. And the research has actually shown us that there's about 45% of individuals with comorbidity. So it's very prevalent there. One condition can exacerbate the other. There's really no, indication of whether you're going to have a mental illness diagnosis before substance. What we do see is that when one is exacerbating the other, an example would be if you have depression, maybe you have major depression, and you are self-medicating with alcohol. So you're exacerbating one illness. And what we find in the acute setting here in the hospital, and we're a Big Rack receiving facility. So when our patients come to us involuntarily, they're not so forthcoming about everything that's going on in their life because they weren't prepared to come and address these issues in the first place because they found themselves in a crisis situation. So there's still that denial and everything that they're battling. But what we like, and while we know as professionals in this field, it's a very unhealthy coping mechanism for you to self-medicate with drugs and alcohol. It's best for the individual, and this is part of what we like to say. And I'm glad we're doing this. This panel discussion is you have to talk about these things that are occurring in your life, especially since COVID hit, because the amount of people that are battling with mental illness and substance use disorders. The numbers are through the roof. They're skyrocketing, and our facilities never been this busy before, ever. And I don't know that that'll slow down anytime soon. So it's important to the road to recovery to really be honest and allow your family, your resources, support systems out there to help you get the right treatment. And you got to be willing to do it.
No, I couldn't agree more. I think that this year has really shined a light on mental health and broke the stigma of people that maybe were afraid to ask for help or not now,
Yeah, I agree. We talked about that. It was probably about a year ago now when we talked about the stigma, and now you can't not talk about it. It's everywhere. It's affecting everyone.
Mm-hmm. Absolutely. All right. Thank you, Amber. All right. We're going to go through one more round of questions. Natalie, talk to me about some of the conditions that you see as a physical therapist in your arena.
Well, because I specialize in vestibular rehab, I tend to see people who have balance problems that are not always diagnosed, but more often than not related to poor inner ear function or function of the connections between the inner ear and the brain. And so that's why, as Dr. Ann mentioned, that anything related to the inner ear is so important. And actually, physical therapists who specialize in vestibular rehab have a good connection with audiologists because we share the same organ, if you will, the end organ of the inner ear. We're very closely related. And so the conditions that we see more often that are inner ear related are something called BPPV. It's hard to say 3 times quickly, and it stands for Benign Paroxysmal Positional Vertigo. Some people refer to it as ear rocks in the ears or crystals in the ears. So there is such a thing as that, and they belong there, but the problem is that sometimes they go travel somewhere else, they misbehave and cause a person to have a sudden onset of vertigo that lasts usually less than a minute. and it's caused by changing the head position. So that is very common. It's the most common reason for vertigo for people who are 65 years and older. And we would think that it's a simple condition to diagnose, but still to this day, there are many healthcare professionals who are not aware of it. So we have that, and then we have infection of the inner ear called neuritis or labyrinthitis, depending on whether or not there's hearing loss. That is also a very common reason for people to actually show up at the emergency room, because sometimes it can be difficult to differentiate between what's called an acute vestibular syndrome or a stroke. So that's why having vertigo can be very alarming and can be dangerous in some instances. We see people with migraines, not that therapy helps the migraines, but it helps to figure out, what are we dealing with? Is it a migraine or is it a direct inner ear problem? And then another one that's very popular is Meniere's disease. There used to be a time many, many years ago, everybody had Meniere's disease. But now that we have a better understanding of the diagnosis, it's still a common diagnosis. And I encourage people that if they have complaints of dizziness or vertigo, to really seek the help, and not just the diagnosis, but also how to live with it and do better and develop compensatory strategies.
Fantastic. Now, you touched on a couple of things that I had on the list for Dr. Ann, and I'm sure she can elaborate on Meniere's disease and vertigo. So elaborate on that a little for me, Dr. Ann.
Sure. So Natalie's right. Some time ago, just about everyone had Meniere's disease. This is really kind of a blanket diagnosis. But really what we doctors were looking for were a combination of symptoms. So classic Meniere's disease would have hearing loss, which would be fluctuating, tinnitus, known as ringing in the ears. Now, this really isn't an accurate description. Tinnitus really could be described as buzzing or hissing or crickets. It's just any sound in our ears or our head that is not present in the external environment. And balance issues. So vertigo, we'd see people spinning and falling. That's what we'd really look for with Meniere's disease. We diagnose with what's called electrocochleogram. And now I think with, more research, more technology, like anything else, we're able to better diagnose. Instead of having a blanket kind of syndrome, we're able to really pinpoint a little better. System's not perfect, but we're getting better at eliminating what's not going on.
Yeah. And much like with Dr. Kai Lewis, technology in your industry has come so far. I think the first time I came in to get my ears checked with you, I was in a booth. The last
that's right.
just a few weeks ago, it was a quick little, what did you put hearing aids into?
Bluetooth. Yeah, that's right. That's right. So everything's wireless, everything's Bluetooth. So the big metal booth has been around for 80 years.
Yeah.
And so a lot of patients still, come into the office and they still expect, to see the big metal booth. Well, we have it, but we don't need it, what we now use, and again, this is something that I've had to learn after school. So Bluetooth technology, wireless testing outside of the booth, and making sure that those test results are accurate with what's called real ear measurements. This has all come after my schooling. But the good news is, the test results are so much more accurate than they used to be, and a huge benefit to patients. So we are the only fully mobile audiology practice in Southwest Florida. I can do this because we have the technology now. I don't have to carry the big, 800-pound booth with me. All I do is I take, little equipment that's maybe 5 pounds. I use Bluetooth, and I'm able to accurately test if there's hearing loss, tinnitus, imbalance related to the inner ears. So like Natalie was mentioning, we really check the inner ears. We check the stereocilia within the inner ears for any damage.
Awesome. Thank you. Perfect description. All right. So, Dr. Ebert, I wanted to ask you a little bit about payments. First off, what type of payments do you accept? Do you accept Medicare? And then also, how often should someone be seeing a chiropractor?
Well, insurance, we do take almost all insurances. It's just, you get patients who say, do you take Medicare? And it's like, yes. It's just there's so many different contracts now with the Medicare Advantage. So we usually try to help walk them through that because they'll have co-pays with it where traditional Medicare, they don't. And we're part of the system, but we're not, it doesn't pay for everything. It doesn't pay for the initial exam, but it pays for the manipulation or the actual treatment. So we just have to kind of talk them through so sometimes I feel like, you're going through this, but you want them to understand, you don't want any surprises. And most health insurance has chiropractic under it. The thing we see is higher co-pays. And so once in a while, I'm just like, well, you're better off being a cash patient because, because it's, I'm not going to benefit with an $85 copay. So, or are they? So a lot of times, it's just going through it. But a lot of times people are very surprised to find out, or they'll go, well, I know it doesn't pay for chiropractic. And all we have to do is my staff, they just go on this website and they're able to pull up people's Blue Cross or whatever they have, and it gives their information. So a lot of times they're surprised that your deductible isn't as high, and also you do have coverage. What was the last question you gave me?
How often should you be seeing a chiropractor?
That varies too, because if you're someone with scoliosis or a lot of arthritic changes in your back, and you're playing golf 4 days a week, and you have all these different things for each person. I have patients who, if they've hurt themselves, I might see them 3 or 4 times in the first week, and then slowly decrease their visits just because they're hurting, they're not playing golf, or they're not able to do anything. So I'm like, well, you're in spasm. Let's get you out where we get you back more mobile. So at the beginning, you see them more often, but when you get into wellness care, when the patient's saying, I'm back to, really pain free, that's when it's like, well, you might benefit once a month. I have a few patients I see every 3 months. I've got some people who, because of their activities and their history, they come in every 2 weeks. They actually said, I want to come in it keeps me out of trouble. Similar to, how often should you get a massage? To me, so I would say a basic wellness program is trying to get in once a month for prevention. And to me, I look at the value, not just the adjustment, but if you're seeing someone fairly regular, you're thinking about, oh, I better lift that, I better use my legs. Or it's like going to the dentist. When you're ready, it's like, boy, I better start flossing more. And, it just makes you more in tune, a little more mindful of what you're doing.
Absolutely. All right. Thank you so much. All right, Dr. Kai Lewis. Now, there is something called cross-linking. Talk to me about cross-linking and if it's right for me.
Well, cross-linking is specifically for folks who have keratoconus, and specifically if your keratoconus is worsening, changing, the shape of the cornea is worsening. So what this procedure is, and is this pretty smart technology, some really smart guy out of Germany came up with it. But what it is, it's they use riboflavin, which is a vitamin B drop, as well as UV light. And what we found is the combination of those two on the cornea over a period of time, usually about an hour or so, actually causes more covalent bonds in the cornea. And so when that happens, so people with keratoconus don't have enough of the bonds, it actually tightens up the cornea and keeps it stabilized. So as opposed to getting your vision back to where it should be, it actually just keeps it from getting worse. And this is really important, especially for folks who who've had keratoconus for a while and maybe progressing, and who needs cataract surgery. You know, sometimes I've seen in the past where folks have had cataract surgery and the cornea starts to change afterwards.
Okay.
So cross-linking can sort of stabilize that and prevent that from happening. So in certain cases, and I've done that a few times here and in Europe, where I've treated someone's cornea before I did the cataract surgery just to prevent it from worsening after the fact. So cross-linking is a pretty, it's relatively new to the States. It's only been FDA approved since like 2016.
Okay.
But, you know, fortunately I did that, you know, for 4 years prior to that in Europe. So I have a lot of experience with it, and you know, it's one of those things. I think it's the only thing we have that can actually stop keratoconus from getting worse. Nothing else.
Awesome. Well, what's the recovery like for someone that might be looking to have this done?
So if you do have a problem and you need cross-linking, often the procedure itself, it is about an hour, and the worst part of the procedure is I have to remove cells from the surface of your eye to get the medicine into the cornea and allow the medicine to work. So the procedure itself is pretty easy, pretty straightforward. What patients have to be aware of, it's a little uncomfortable the day after. I don't know if you ever, you know, scratch your eye with a mascara pen or anything. It's not the most comfortable thing in the world. So, but typically it's just about 1 to 2 days. The vision is relatively blurry because the cornea has to heal up. So most people by the end of the week are doing a lot better. And often if you need to change your prescription or get back into contact lenses, usually about 4 to 5 weeks after that, you can do so.
Okay. All right. Well, it doesn't sound too bad. A little scary, but you might have to knock me out if I ever have to have that done. All right, Amber, we're going to wrap things up with you. Now, in your expertise, what services would you like to see developed in your arena?
Yeah, so with COVID, you know, like I mentioned, the numbers are through the roof across the board for mental illness and substance use. So we have an issue with supply and demand, and that stems immediately with the funding that we have allotted right here for us to be able to develop anything for behavioral health. So, I mean, funding would go a long way here in Florida, but we're limited with resources right here in Lee County for whether that's going to be education available to patients in need, whether that's allowing access or gaining access to providers, that's medication, that's shelters, transitional housing. I mean, there's so many areas that we can develop. I think if you're a healthcare worker or a provider in the community, you want to see reimbursement rates more, you know, proportionate with maybe other areas in healthcare. Then there's, you know, that collaborative approach and partnership with community, you know, other community organizations that see these patients. We talk about primary care providers. They see patients all the time who are struggling with mental illness and addiction. So like I said, there's so much opportunity. What we want for patients, clients, residents, however your organization classifies them, it just doesn't work so well right now with the current funding allotted and the limited treatment facilities and demand that there is here in Southwest Florida. So we do have a lot of opportunity to develop across the board.
Definitely. And continuing to do that education in the community and really make people aware and breaking that stigma is of the utmost importance right now. All right, perfect. Well, thank you guys so much for joining us. For our viewers, if you can just put your questions in the chat, we will get your answers to you right away. Thank you so much. And we appreciate you being here. We look forward to seeing you